My name's Brendan Fitzgerald,
And I'm Tyler Ellison.
and we had a 24-year-old club soccer player and a referee who had a grade 3 tear to the right anterior cruciate ligament. Introduction. So our patient was Leonor Ronaldo. He's a 24-year-old construction worker for his father's business who loves refereeing soccer games in his free time on the weekends and also plays in a year-round club soccer team with all his buddies. 2 weeks ago, while he was refereeing a game on the weekend, he had a quick change of direction on the right knee and heard a popping sound and fell. After diagnosis, it was determined that he had a grade 3 tear to the right ACL. With his active lifestyle and how young he is and still enjoys playing soccer, we determined that an operative treatment with surgery was the best option for Lionel. He was sent to our clinic 2 weeks prior to the surgery for some preoperative treatment to focus on pain and limit edema.
So now we have ACL anatomy and MOI, or mechanism of injury. The anterior cruciate ligament, or ACL, is a short and sturdy ligament connecting the femur to the tibia. It runs laterally to medially, just anterior to its partner, the posterior cruciate ligament, or PCL. Common movements that lead to ACL tears are torquing, shear forces, twisting motion, and hyperextension of the knee, which are very common in a sport like soccer, with the rapid movement and a lot of excessive running and sprinting. When an ACL tear occurs and surgery is warranted, a graft may be taken from a variety of different places directly from the patient, which is an autograft, or from a cadaver, which is an allograft. Potential grafts are patellar tendon, hamstring tendon, or quadricep tendon.
So some signs and symptoms that our patient presented. There was swelling and effusion edema that occurred immediately after he fell. After tearing it, it felt like there was unstable or no stability within his right knee. As he was falling, also there was a loud pop that occurred in his right knee when he fell to the ground. Pain is typically not experienced if ACL ligament is the only tissue injured. However, if there's more tissues involved in the injury, pain is more commonly associated with the knee injury. The initial care for an ACL tear includes RICEs, so ice, compression, and elevation to the knee, and then NSAIDs, also to help with pain and inflammatory response. Obviously, as soon as this injury occurs, you want to get to a doctor immediately to assess the injury and if any other structures are damaged. Surgery will most likely be needed.
Alright, so we have the inactive part of treatment. So our goals for the inactive phase are just to decrease edema, which is very important for the recovery process. So we'd like to decrease the right knee girth to 45 centimeters by April 20th, 2018. To do this, we'd like to use light effleurage, RICEs, which is rest, ice, compress, elevate, and stabilize. And then we'd use NSAIDs to also control pain and decrease inflammation. For our second part of the inactive goals, we'd like to increase and maintain passive range of motion for knee extension. To increase the passive range of motion for knee extension to 0 degrees by April 20th, 2018. To do this, we'd use knee sags, prone leg hangs, using a bolster under the distal tib and fib, single leg, mini heel slides, and calf raises are also good exercises to increase his passive range of motion for knee extension. And then lastly, we'd like to control and limit his pain, which is very important for his process of rehab, allowing him to fully get the most out of his exercises. So we decrease the patient's pain to a 2 out of 10 at rest by 4/20/2018. All right, here we have the patient doing knee sags. And for knee sags, we're going to have the patient seated on the table with the right leg fully extended. You will then place a bolster under the distal tibia and fibula and allow the knee to passively extend. This allows the knee to work into its full range of motion for knee extension without any harmful forces placed on the knee.
So in the active or early stage, our goals are we want to focus on increasing the active range of motion in knee flexion and extension. We also want to focus on strengthening the quadriceps muscle group back to normal. And we want to also start working on proprioception and muscle stabilization, just so we know our patient can feel sturdy and strong again on that right leg. So for range of motion, our goal is to increase active range of motion knee flexion to 110 degrees pain-free by 5:25:18. We do some light one-legged leg press, towel slides, and seated chair walks as exercises to focus on that goal. For the quadriceps muscle group, we want to increase vastus medialis manual muscle test to a 4 out of 5 by 5:25:18. To do this, we'd do some quad sets, some isometric quadricep contractions, single leg straight leg raise, and active range of motion knee extension. For the proprioception and muscle stabilization aspect, our goal is to have the patient stand with eyes closed on one leg for 30 seconds by 5/25/2018. To work on our patient's proprioception and balance, we will have the patient perform one-legged calf raises while also bringing a finger to the nose. Have the patient standing on the affected leg, performing slow and controlled calf raises and touching the nose after each repetition. Continue this movement through the entire set.
So now we have the resistive middle phase of treatment. So our goals for resistive middle phase for the rehab process is going to be increase active range of motion for knee extension and flexion, and to increase our knee extension to full knee extension and knee flexion to 135 degrees by July 10th, 2018. To do this, we're going to perform leg curls in a sitting position. You want to use a sitting position because a laying position will put more stress on the leg, causing potential injury. We are also going to use the stationary bike, which is very crucial for working knee extension and flexion at the same time. So our second goal is to continue to increase strength of quadricep muscles and glutes, which are going to build the quadricep muscles which stabilize the knee. To be able to hold a wall sit for 2 minutes by July 10th, 2018. Perform active body squats for 3 sets of 15 and continue with quad sets. And then we're also going to do squats with a lightweight, possible glute bridges, and then towel slides, working on that full range of motion. We'd like to introduce the patient to the treadmill as well, just with him being a soccer player, getting his endurance up. So we'd like him to be able to jog on the treadmill for at least 10 minutes by July 10th, 2018, and then work on his endurance and warm up with stationary bike before exercises, just getting a nice little warm up before exercise. We'd also like to focus on maintaining proper gait and jogging and light running for his techniques when he's running. And then our last goal is to increase proprioception and leg stabilization to stabilize his leg muscles. We'd like to use one-legged calf raises, which are eyes closed, to increase his proprioception, and also Bosu ball squats to increase his strength, balance, and proprioception. Patient standing with feet shoulder width apart against a wall, and this is a good exercise to strengthen the glutes and the quadriceps. So we're going to have the patient perform a wall sit, bend the knees at 90 degrees, and flex the hips, and just pretty much rest up against the wall. And then have that patient hold that for whatever time you desire, preferably about a minute, working on a little bit of strengthening and endurance of the muscles, having them hold that isometric contraction rate. So
for the last stage of treatment, for the aggressive relay phase, our goals are to increase his functional movements or his sports-specific movements. We want to increase his hamstring, his right leg strength. Had a lot of physical therapy and atrophy to those muscles. We want to build that strength back up. And then we also want to return Lionel back to full participation in work and in his everyday life, his activities, soccer, his club soccer team. So our goals for that, we want to increase his one-legged step-ups to complete 10 in 30 seconds by August 30th, 2018. To do that, the exercise we'll work on are some lunges, some step-ups, jump squats, a lot of proprioception or plyometric work to focus on that functional movement. Increase the patient's vastus medialis manual muscle test to a 5 out of 5 pain-free by August 30th, 2018. To do that, we'll do on some knee extension, weighted, and then we'll do bounding for plyometric exercise, focus on that quad strength. And then return patient back to full participation in work and his soccer activities, pain-free by 9/7/2018. For the aggressive relay phase, we want to focus on plyometric or functional and sport-specific exercises. So we'll have our patient perform scissor jumps, have the patient go down into a lunge position, and then explode up, jumping, while switching legs, and continuously performing a scissor jump. For zigzag cone drills, we have our patient dribble between the cones like an obstacle course, down and back. The patient wants to focus on using sport-specific movements, cutting and running through the cones, and practice dribbling to get back to full speed playing soccer.